So I guess it's good afternoon, good evening, or good morning, depending upon where you're joining us today. But on behalf of Axiom, we'd like to extend a very warm welcome to everyone. Really looking forward to today's discussion, kind of post ASH. We're joined today by an expert panel, and we're looking forward to the discussion. I think, from an Axiom perspective, one of our kind of core missions as a think tank is really to kind of help bridge that knowledge gap, from its academia to our industry partners, as well as to the community and patients at large. Today's town hall, as I mentioned, the core focus is going to obviously be within hematology post ASH. I myself am John Yoder. I'm also joined by my colleague, Justin English. And today we have kind of some of our esteemed colleagues here, Dr. Banerjee, Dr. Stahl, as well as Dr. Lynch. And I will let each of them give their own intros because I likely would not do it proper justice. And then we will kind of carry on with today's discussion. So Dr. Stahl, why don't you go first?
Sure, yeah, I can go first. So yeah, Max Stahl from Dana-Farber Cancer Institute in Boston. I'm taking care of patients with acute and chronic leukemias, and a particular focus on AML and MDS. Nice to be with all of you.
Welcome. How about Dr. Banerjee?
Great. Hi, everyone. If you were to start Dr. Stahl's office at I-90 and drive all the way west until you hit the water, then you'd be in Seattle. That's where Dr. Lynch and I are. So I'm Dr. Banerjee. I'm assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle, Washington, specializing in multiple myeloma, BCMA-directed CAR T therapy, AL amyloidosis, and so forth. Very nice to be here. Thanks a lot for listening.
Welcome. And Dr. Lynch, also from our West Coast cohort here today.
Yeah, probably in the same building as Dr. Banerjee right now. But yeah, so Ryan Lynch. So I focus in lymphomas here at Fred Hutch in Seattle. And so we have a portfolio more recently focusing on novel agents like bispecific antibody therapies and untreated patients for indolent and aggressive non-Hodgkin lymphomas, as well as evaluating the role of MRD, not just in non-Hodgkin lymphomas, but as well as Hodgkin lymphomas. Very happy to be here. Thank you.
And welcome. And I'll pass it to you, Justin, to take us away with some of our initial questions.
Great. Yeah, thanks, John. And thanks, Dr. Stahl, Banerjee, and Lynch for being here. Really excited to talk to all three of you. I think this provides a nice bow on the year in hematology, particularly, following in the sort of post-Congress pre-holiday, area we are in right now. I think over the course of the next hour, I want to cover, kind of three key themes, and hear from each one of you with regards to those themes, given, the questions and answers are likely going to differ based on the variety of specialties we have here on the line. But first, I want to start with the current use of key modalities, and in particular, I'm curious to hear perspectives on the use of cell therapy and bispecifics. And, I know for you, Dr. Stahl in particular, AML poses a number of challenges and has posed challenges to the development of those types of therapies. So maybe you can speak to the challenges, and Drs. Banerjee and Lynch can speak to, where we've seen success, how you're thinking about therapeutic application of one or both of these modalities. Maybe let's start with the challenges first. That potentially could be an interesting way to kick things off. So, Dr. Stahl, curious for your thoughts on application of these modalities in AML.
Sure. Yeah. So, I think we definitely recognize that the immune system plays an absolutely essential role in AML, just like in all the other diseases. We know this because we don't cure many AMLs, only certain subsets without bone marrow transplant. And bone marrow transplant is really the first immunotherapy, described, and still probably one of the most successful ones. So we do recognize that. And because of all of the success of our colleagues in myeloma and, ALL, we, of course, would love to use bispecifics and CAR T cells. And we have tried this in many different trials. I think the trials have been underwhelming so far. And the two big issues have been, one, toxicity. We have a lot of CRS in those trials. But the bigger issue is honestly lack of efficacy, that those trials didn't work out so well. Response rates are not so high and they're not very durable. And I think, there are a couple issues. I just can, touch on a couple very basic issues. But I think number one issue is that, it's the target itself, right? So, in ALL and multiple myeloma, you're blessed with a target that is dispensable. So in ALL we use CD19 directed CAR T cells and bispecifics with blinatumomab. And we know that lives on B cells and it depletes B cells, right? But you can live without B cells. The problem is you cannot live without myeloid cells. So if you direct CAR Ts or bispecifics against CD33, CD123, which are typical myeloid antigens, that is much harder, leads to much more cytopenias, much more infections, and neutropenic fever and other issues. So that's number one. Number two, I think, is a little bit more, and this problem at least, is being targeted by multiple issues, trying to find different targets that are more differentially expressed between normal hematopoiesis or normal granulocytes and leukemia cells or leukemia stem cells. But the second issue is also that T cells in generally don't seem to work that well in AML. So even when you get CRS, this has always been the conundrum with cellular therapy, I think, in AML, is that typically when you get higher CRS rates in ALL and other settings, that usually translates into toxicity, of course, but also efficacy. It means the T cells are working. And that is not quite the same in AML. So a lot of those cells are just not very good, and they become anergic very quickly when used against AML. So, they're just not active the way they are in other diseases. That does not mean we have given up. It's too important to give up on that field, but those are kind of the formidable challenges, I think, that the field faces in AML.
Yeah, and I've seen there's still exploration of CD123 as a potential target.
Yeah.
I saw there's this interesting sort of dual targeting CAR T from MSK,
Right.
ADG-RE2 and CLEC12A. So to your point, a lot of challenges posed by the disease biology, but who knows what the future holds. Curious, Dr. Banerjee, maybe your thoughts on an area where we have seen pretty significant success of both cell therapy and bispecific application.
I mean, yes and yes, right? In myeloma, they've been great for our patients. And it will be interesting to see little nuances here. So I think definitely, BCMA CAR T, for example, in the myeloma space, we saw a lot of really nice data with CARTITUDE-4, with cilta-cel and overall survival benefit. Anito-cel was presented there, which I'm sure we can come back to, which, maybe another target, a synthetic epitope to target BCMA. We saw BMS 986393, which is a GPRC5D targeted CAR T, now known as Arlo-cel. Not worked very well with or without prior BCMA. On the bispecific arena, we've seen a lot of great successes in terms of these drugs working quite well. So the one that really, I think, stole the hearts of many of us in the audience in a fascinating way was Majestic 5, presented by Dr. Mark Robb and colleagues from Heidelberg, Germany, where they gave teclistamab as part of frontline induction. So BCMA-directed therapy is part of induction for transplant-eligible patients, TEC-DARA-R, TEC-DARA-VR. 100% of patients MRD negative at 3 months. I would argue with friends like that, who needs transplant, right? So in a world, there might be a scenario someday we don't need to be doing auto transplant for myeloma anymore because of these bispecifics. What's interesting and the Achilles heel of bispecifics are the sequencing. So I'd be curious to hear Dr. Lynch speak next. I've heard that in lymphoma, nobody cares about sequencing, but in myeloma, we obsess over it. That if someone's BCMA exposed with a BCMA CAR T therapy, can they get a BCMA bispecific? If they get a BCMA bispecific, can they get a BCMA CAR T? One of the really interesting things is we as a field in myeloma often say BCMA first, GPRC5D later. If you were to ask us why, just because that's the way that the trials came out, that we had BCMA and then GPRC5D came in and so forth. And thus we just have people march from CD19 and then on to BCMA, something along those lines. What will be really interesting, and it was work by Dr. Dakhal, Binod Dakhal presented data with talquetamab, so GPRC5D first before BCMA. And that was really interesting, that can we just flip the script now and sequence things differently? No matter how you sequence it, myeloma is still incurable, I think, is one of the tricky parts about this. So people are still having relapses no matter what, but I think we're making progress. So I would say, in brief, bispecific CAR T have had a lot of amazing success stories. We can talk about the side effects. I don't want to dominate this conversation. We could talk about bispecific side effects all day, but I think the big thing is that there's still a lot we don't know about how to combine them, and more importantly, what order to put them in.
Yeah, absolutely. And I think you kind of tee up nicely after this conversation. Talking about sequencing is critical across all three, or three of your sort of treater expertises. But Dr. Lynch, curious for your thoughts in the lymphomas. Thinking about Breyanzi use, application of bispecifics. I think there's nuances that exist within lymphomas, particularly CLL is inherently maybe not bispecific friendly based on the disease biology. But I'll let you kind of expound on that
So,
a little bit.
Rahul, you bring up a good point. Actually, a quote that I've been using a lot at various meetings at ASH was, we are entering the era of myelomification of lymphoma, where we're going to have these options, and a lot of things are going to be coming down the pipeline in terms of both registry studies and untreated and relapsed patients. But they're not going to help us know what we should use or how we should sequence them. Or if you use one, then you can't use the other. So this year is coming for us, Rahul. Don't worry, we'll be there soon enough for this. So I do think there are certain inherent advantages to bispecifics, and you have the ability to give them off the shelf quickly. There are outpatient management strategies which are easier in the lymphoma space. ICANS is essentially almost unheard of with good prophylaxis, and high-grade CRS is pretty uncommon too. And so it does lend itself to more outpatient management. Even smaller clinics could do it. I think so. In the large cell lymphoma space, there's almost like, to use a Game of Thrones reference, of the big wall has been formed by CAR T in the second line space, and it's very insurmountable because I think we know that's extremely effective with good overall survival data in second line refractory patients, but it makes it challenging for us to move beyond that paradigm. And why that's important is that there are definitely long-term risks and toxicities you see with CAR T that you do not with bispecifics. So 7 years ago, when CAR T was first approved for lymphoma, when the alternative was essentially death, we were all very grateful to have these options. But now I'm not sure that everybody needs to get one if we can figure out how earlier in the disease course we can use bispecifics to prevent the need for CAR T and long-term immunosuppression, hypogammaglobulinemia. These patients have problems. Things are not normal. And we know from real-world data that non-relapse mortality is about 3% per year, and it's continuous after CAR T. And that probably is the case for other diseases as well. So I think those are kind of the big things and where the studies are in the field. And those are, me, the big picture issues, lymphoma.
Yeah. I think maybe kind of both of your insights kind of lead us into the next question around sequencing and how we're positioning all of the options we have at our disposal. Maybe again, starting with MM. This year I think was a banner year for CAR T moving up in the earlier lines of therapy, supported by KarMMa-3 and CARTITUDE-4. But then also, a lot happened in frontline, which is going to impact the sequence of options following that. And then, when we think about the continued investigation of all these assets, everything is moving up earlier. And so your arsenal and what's available to you becomes greater and greater. And then it's a question of, how do I deal with this ever evolving algorithm that is just getting more complex? So Dr. Banerjee, curious to hear your thoughts on how you're thinking about the order of operations, CAR T versus bispecific, as well as the additional layers of changing paradigm even earlier, and then target, whether it be BCMA versus GPRC5D, and then, down the line, FCRH5 and others that are likely to enter.
Great question. So I think the bottom line, I would say, is that unlike our lymphoma colleagues, we're not curing anyone yet, not reliably so. And so we have work to be done, but we're getting better at it. So I would say put your best foot forward now and just figure out the future out when that time comes. And so, it's hard because a lot of people are worried. For example, with Majestic 5, I alluded to it, teclistamab in frontline induction did amazingly for transplant eligible patients, but people are worried, well, if you do that now, then they can't get BCMA CAR T 3 years from now. Who knows? We'll have some other CAR T therapy available then, or as you allude to, another product or a tri-specific antibody. So a lot of options there. In general, I would say that BCMA, because there's so many options and because we've kind of optimize a lot of our BCMA with bispecific in particular, our prophylaxis strategies, because infections are the big issue with BCMA bispecifics, and we've kind of figured out with IVIG and prophylaxis a strategy to manage them. I generally favor BCMA targeted therapies first before moving to GPRC5D, because we're still figuring out how to optimize GPRC5D therapies. You mentioned cevostamab, so FCRH5 did okay. In that study, Dr. Richter presented the data, and it was like great to see it come together, but it was like a 40-50% overall response rate, a little bit lower than I might like to see. And then maybe the cevostamab needs to be partnered with something else to work even better. Because with talquetamab, for example, we're seeing that TAL plus POM works really well. Or, you're kind of prompting me to say BCMA versus GPRC5D. Why not both, right? There was data at ASCO published soon with Redirect 1. Teclistamab and talquetamab target two proteins at the same time, and those patients do amazingly, even those with visceral EMD. So I would say that being said, like the future is bright. I would say probably BCMA first in general, because we're still learning to optimize GPRC5D. In terms of CAR T versus bispecific, Krina Patel, one of my colleagues at MD Anderson, phrased it well. Like whenever a patient's on a bispecific study and it stops working, they always ask, what's the next CAR T available for me? Whenever they're on a CAR T study and it stops working, they ask, what's the next CAR T study available for me? Patients, at least with myeloma, love CAR T therapy in general because it is a treatment-free interval, which we never get outside of that in multiple myeloma ever, basically. And so I would generally favor CAR T therapy first for patients if they can tolerate it. I'm just saying it from a patient preference perspective. Always a discussion needs to be had. There is a lot of angst in the field that if you start with a BCMA bispecific or a bispecific, and then you go try to collect T cells, you might exhaust those T cells. In real life, there's a lot of speculation. We in the myeloma field have speculated all sorts of times. And, there's a joke that, like the dumbest tumor cell is smarter than the smartest oncologist. I say the same for our T cells, right? So I have had patients who I put on talquetamab for holding therapy before T cell collection because they were going to die otherwise. And then I stopped the TAL, gave them T cell collection, resumed the TAL, and then went back to BCMA CAR T, and they're doing great. Right. And so it's proved that it is possible to use a T cell redirecting bispecific before T cell collection, but there's a lot we don't know.
Maybe just to orient Dr. Stahl to the conversation and then pass it to you, Dr. Lynch. We're kind of talking about sequencing considerations in your respective indications. And I'll be curious to hear your thoughts after, particularly with the sort of menin revolution that's kind of undergoing and was a major story in AML. But Dr. Lynch, with regards to sequencing, I'm curious to hear about your thoughts. How you're thinking about not only bispecifics and CAR T in the lymphomas, but alongside established options like the BTK inhibitors. As things continue to move up, how you're going to orient maybe bispecific based combinations with things like R-CHOP. Frontline CAR T studies, supported by things like Zuma-23, kind of the holistic view.
So, I think the story is still being written in the large cell lymphoma space. So what you're describing is really defining the questions are going to be answered over the next several years. So how do we integrate bispecific antibodies? Do we combine them with antibody drug conjugate like polatuzumab? Do we combine them with R-CHOP? And then and then in the relapse setting, those studies are ongoing too. So in terms of sequencing, we're limited now just because of the label, but the confirmatory studies are coming. So I do think at some point the best role for bispecifics will probably be in untreated patients. I mean, I have a feeling the studies will be designed. Some, at least one, if not all, will end up being positive studies, and we'll be very comfortable with that. I think Zuma-23 is pretty controversial, and so this is frontline CD19-directed CAR T-cell therapy in large cell lymphomas for high IPI patients. And, this is, I think, I think I struggle with this a little bit because I think if we have good, quick access for primary refractory patients with lymphomas, we probably don't need a Zuma-23-like strategy, meaning the only reason Zuma-23 would work is if there's absolutely no time to get someone to CAR T when they relapse from lymphoma. And the other reason I struggle with it is, even though these are high-risk patients, IPI 4 and 5, who are getting CAR T up front, some of these patients are still destined to be cured. And so, it's a matter of taking more than one shot on goal. And that's the sports metaphor I use. So instead of, 40% shot, why not get a 30, 40% shot plus another 40% shot, and you're increasing your chances of survival. And so that ZUMA-23 type strategy is going to need a lot of mature data to really show that that should be first. And especially given the long-term effects we see with CAR T, I'm just not sure you want to do that unless you absolutely have to.
Yeah, a lot of different safety and sort of patient journey related considerations to take into account.
Yeah, and we know with bispecific antibodies about median time to B cell recovery when you stop. So unlike with Dr. Banerjee, curative intent, if you got bispecifics on front, curative intent, it's about 15 months, at least in the relapse setting, it's about 15 months or so median time to B cell recovery. You can get people through that. If they need IVIG, you get it. You don't always need it, but that's a pretty finite period of time versus with CAR T, sometimes that CAR floats around for years and years and years. And you keep checking the B cell levels and they're zero, like years out. And you just don't know when that's going to end. Versus bispecific, it's pretty finite.
Yeah, the predictability versus unpredictability plays a significant role. Yeah. Dr. Stahl, curious for your thoughts. I know kind of getting away from maybe the cell therapy bispecific conversation, but more about sequencing in AML. Given the challenges the diseases pose, but also the interesting degree of success we've seen from menin inhibitors in the relapse setting, with the goal of menin plus something like 7+3 chemo as a frontline option. Like, how do you see this story playing out, and how that's going to impact subsequent lines of therapy moving forward? Sorry, you're muted.
One would think I would know by now, right? But so the menin inhibitors, I think, are a perfect example. Like if you would say to somebody, well, you have a new drug, it has a response rate of about 25%, and it lasts about 4 to 6 months. Why is everybody so excited about this? Right? It doesn't sound very exciting compared to what the guys do with myeloma and lymphoma, right? So why are people excited about that? Well, because the way we approve drugs in AML and in other oncologic diseases as well is to start with kind of the worst population, multiple relapse refractory patients, right? That's how the menin inhibitors were first tested, for NPM1 mutated and KMT2 rearranged acute leukemias. And in that, you get the response rate that I mentioned, but not much toxicity. With the first menin inhibitor, revumenib, you got some QTc prolongation. The newer menin inhibitors, ziftomenib, enzomenib, and others don't really have that issue as much anymore, And apart from that, you only get differentiation syndrome, which, leukemia doctors would say is not really a side effect. That's part of the mechanism, and we can control for that, not to talk it's as a small issue, but, in those patients, we are grateful if we have something like differentiation effect, because we feel like, we treat the underlying disease, right? So based on that limited response rate, revumenib was approved in the relapsed refractory setting, but the excitement is always moving those up front, right? Because we know it's a very tough population to treat venetoclax pre-treated patients. And when you look at those trials that you use single agent in the relapsed refractory setting, that gets to your sequencing question. All of them had venetoclax-based treatment basically before. 70% or so of the trial patients got venetoclax pre-treated. And we know from data from MD Anderson that those patients who are relapsed refractory to venetoclax have a median survival of, 4 months, right? And nothing really works. Not chemo, not other drugs, So it's a very tough population to treat, So the realization that the menin inhibitors still have responses in some of those patients and are overall well tolerated gets people excited, So now in terms of the sequence, they're going to be moved forward in basically every setting you can imagine, right? Intensive chemo, less intensive chemo. So with 7 and 3 as induction, with HMA-VEN for older patients as a triplet combination. We have an investigator trial here with a quadruplet combination, 7 and 3, midostaurin plus revumenib, so similar. We're trying to catch the myeloma folks, with quadruplets, right? So it will be in every combination that there is. And the idea is that in generally those drugs are fairly well tolerated. They don't lead to much or as much myelosuppression as other drugs. And they might get people to a very deep remission, what we call an MRD negative remission, which in certain subsets of patients, for example, NPM1 mutated patients, can spare patients transplants in CR1. So there is benefit of that to getting deeper remissions because you might cure more people without a transplant. So I think that's what gets most people quite excited about those drugs.
Yeah. No, I think it's fascinating, and it's great to see for a disease that has had, failures and has been so challenging, particularly compared to the rest of heme in terms of development of novel therapeutics. I think it holds a lot of promise, and it was great to see, a lot of the conversations happening at ASH, and will be great to see things happening in the future here. So, thus far we've talked about use of options, sequencing considerations. But I also want to kind of maybe expand a bit more on the safety side of things, and management of the toxicities that are associated with these therapies. And I think Dr. Banerjee, you mentioned it a little bit, and Dr. Lynch kind of alluding it to it a bit in terms of introduction of things earlier in the lines of therapy. You kind of bring about certain risks that maybe those patients wouldn't normally be exposed to, their health, quote unquote, healthier at baseline. So I'm curious, we can kind of go around again, ending on Dr. Lynch, but maybe first, Dr. Banerjee, how are you thinking about management of tox as it relates to both cell therapy and bispecifics? I think a lot of, great work has been done on prophylactic tocilizumab, more aggressive use of IVIG supplementation. So curious to hear about, experiences with that and, sort of real world implementation of management strategies.
Absolutely. Great question. So yeah, I mean, I think you can bucket the toxicity into two categories. One that all of us could talk about easily is CRS and ICANS, and a separate everything that happens thereafter. So I'll start with the other one, because the second half, because that's a little bit more interesting and more nuanced. So for BCMA bispecifics, exactly right. The infections are a big problem. There was an oral abstract at ASH that showed that primary IVIG prophylaxis, it was retrospective, so some confounders here, but primary IVIG prophylaxis, meaning start it somewhere during cycle 1, start now, ask questions later, versus waiting for an infection or waiting for the IgG level to fall below 400, there was a mortality benefit to starting early. Again, some confounders there, but I think that's good enough for me to say, look, I start my patients on IVIG from the get-go. That's helped a lot. I use antiviral prophylaxis, I use anti-PGP prophylaxis, and so forth. And spacing out the dose, right? And we'll talk about that. I think a common theme for all of it, if you space out the dose, the toxicities will magically get better. So moving out to Q4 or Q8 or even Q12 week bispecifics. For talquetamab, we're still figuring it out. That's the GPRC5D one that can cause tongue issues, skin issues, nail issues. Ask me again in a year, and I think we'll have a better sense of it. But I think the key part is to be aggressive with like Dexoral mouthwash or ammonium lactate skin things. And again, dose de-escalation. There was an abstract at last year's ASH by Dr. Chari and colleagues that's showing that if you move patients from Q2 to Q4 week talquetamab, which is not the package insert, but was a cohort of Manimontel 1, most toxicities got better. And routinely in my practice, I moved patients to monthly talquetamab by like cycle 3 or 4. Again, the max tolerated dose with a bispecific antibody is not the optimal biologic dose for the patient. That's true again and again and again. For CRS, ICANS, and other things. For bispecifics, for CRS, I think the big thing we're moving to in myeloma is outpatient bispecifics. Many of the big centers are moving towards that now. We really embrace this idea of pocket dex, so pocket dexamethasone, where flipping the script, where all of us trained or started CAR T in a world where Tosi first, never give steroids unless you're having bad neurotoxicity. Because for CAR T, I get it, $500,000 investment, you want to be careful. With bispecifics, who cares? At least in myeloma, we give dexamethasone anyways as a pre-medication before the first couple of doses. You can always give more dex. And so we actually now saying for our patients, here's dex 10 milligrams. If you have a fever, call us. We'll tell you to take it and then go to our ER. And that has helped a lot. Just dex won't make CRS go away. Someone's destined to get CRS, they're going to get CRS, but at least makes all of us feel better. They're not sitting in the ER with a temp of 104 on a Friday night. Mm-hmm. For CAR T, I think the big unanswered toxicity question is Parkinsonism, delayed neurotoxicities that can happen, particularly with BCMA targeted therapies. So cilta-cel in particular has been associated with it. It was like 6% in CARTITUDE-1, now 0.6% in CARTITUDE-4. So probably some of it is disease burden and controllability and so forth. Anito-cel, at least now with 100-ish patients, has not shown any. That doesn't mean it's not possible, because even ide-cel has had some happen, but it's really interesting. So I think the literal million-dollar question in the myeloma field is, how do we figure out who's going to get this Parkinsonism, and how do we stop it before it happens? And we have some ideas that some of it may be disease burden, some of it may be how quickly the lymphocytes proliferate. We have a lot of ideas, a lot of conjectures that we make when we see it happen, but we don't really know. So I think that's one unanswered question. So I don't have a good answer for that one. Everything else, I think we're making good progress on.
No. And I think the delayed neurotoxicity is a very interesting question, and kind of can lead towards the end when we talk about novel entrants. Anito-cel, I think, is the top of my list when I think about differentiation within this space. But Dr. Lynch, curious for your thoughts on management of tox, and particularly as a function of treatment sequencing across the lymphomas.
Yeah. So, as I mentioned, the sequencing story is still being written, right? I mean, I think how bispecifics overcome like very strong second line overall survival benefit data with CAR T is to essentially fly over it and go into first line setting instead of attacking it head on. And it's certainly scalable. All of the toxicities that Dr. Banerjee mentioned can happen with CD20 bispecifics. They just happen less often and they're less severe. And the depth of immune suppression is also not as deep. So without IVIG, you give someone BCMA directed therapy, their IgG would be like undetectable. Like, I mean, it's probably not like that anymore, but originally it can be very low if you just don't do anything about it. Versus in B-cell lymphomas, you might get to like 300, 400, 500, maybe never even below 500. So you do get some infections, but the depth of immune suppression is not nearly as deep for these patients. So, and the CRS is much less common. So same thing, we generally manage these as an outpatient. And so like sequencing question, we certainly can't answer now. And in terms of CAR, worry less about, with Breyanzi and those 4-1BB products, like high-grade CRS and ICANS is much less common. We do give that product as an outpatient and only admit in the setting of CRS or ICANS, sort of like a day hospital type model, which has been well set up here and was adapted from the outpatient auto program that we set up decades ago here. And so for that, we worry a little bit less, but I think the future question 3, 4, 5 years from now, whenever these studies read out, the sequencing question is going to be also the long-term toxicity. So it's going to take time for us, especially with CAR, to make a really good head-to-head comparison about should we be giving that up front versus bispecifics if those studies read out.
Yeah, it's interesting to hear about the respective nuances that exist between your respective indications. Dr. Stahl, kind of passing to you, sequencing considerations in AML and safety considerations. And I'm curious to hear how you approach the sort of looming threat of differentiation syndrome. As I think you kind of alluded to, it's almost expected because it's one of these like on target results. But curious to hear about management, of that in your patients.
Yeah, so I think with differentiation syndrome, the important point to mention is the risk of differentiation symptom really depends on in what line of therapy the menin inhibitor is used. And that's directly related to the disease burden and what other types of therapies are used along with a menin inhibitor. So if you have a patient with relapse refractory disease, high blast percentage, and use a single agent menin inhibitor, you have quite a significant risk of differentiation syndrome, because there's a lot of leukemia around. In the trial that was presented at ASH with ziftomenib and 7 and 3, where they had 100% response rate, right? They had very, very low rates of differentiation syndrome because the chemotherapy debulks the disease so quickly that when the menin inhibitor comes in, really you don't have much leukemia cells to give you differentiation syndrome anymore, right? So, and that is very similar to what we see with patients with acute promyelocytic leukemia, where we say so-called high risk and lower risk patients. Higher risk patients have higher white blood cell count. They're mainly higher risk because they have a higher risk of a differentiation syndrome, and they have a higher risk of differentiation syndrome when they have this high white blood cell count. So I would say how currently this is managed is just by close observation and steroids when they get differentiation syndrome. But we might get to a point similar to APL, where in higher risk APL, a lot of the protocols use prophylactic steroids, from the get-go for the first couple of days until the disease is debulked. Has not been done really with the menin inhibitor trials, but that might be a strategy if you run into a lot of differentiation syndrome with single agent menin inhibitor in the relapse refractory setting. In the frontline setting, I don't think you will really need that because you get debulking of the disease very quickly. So in those, I think steroids can really be reserved for the rare cases you get that. We at our center, we don't give prophylactic steroids because we monitor those patients very closely. We check their weight daily. their weight goes up rapidly, which is usually an early telltale sign for differentiation syndrome, even before they get fever and, shortness of breath and tachycardia. We give steroids very early. But in other centers where you're more removed and it's a little bit harder, shorter course of steroid, prophylactic steroids for those single agent menin inhibitor in the relapse refractory setting might be a way to explore, and to reduce that risk. But in generally, leukemia doctors, that is not our major concern, I would say.
I'm glad you bring up the menin inhibitors again and kind of tie into that conversation, because it leads nicely into what I want to ask you all next is how you're thinking about the ever-growing armamentarium of options that are available in your respective indications, both currently approved, but also more importantly, everything that's still being investigated and multiple sort of iterations of the same mechanism of action-based asset. And starting maybe with you, Dr. Stahl, I'm curious, what do you make of the increasingly competitive menin inhibitor space? At least 4 agents on the horizon, all sort of jockeying for position and fighting for, maybe a piece of the pie that accounts for upwards of only 30% of all the patients. Is there reason to believe there's meaningful differentiation amongst these, and like how are you sort of reconciling, something that isn't first, and all the things that come after the first approved asset?
Great. Yeah, that's a great question. I think 2 aspects to this question. Number one is, can you improve on the toxicity of an agent, right? And I think you can. Most of the second and now third generation menin inhibitors, they really have much less QTc prolongation, and they don't have much CYP3A4 interaction compared to revumenib, right, which is an agent that got approved for KMT2A rearranged leukemia and will probably be approved for NPM1 mutated leukemia. So that is an improvement, right? Because if you don't need to monitor QTc time all the time, that's important. In addition, we have many other drugs that are QTc prolonging. So for example, FLT3 inhibitors like quizartinib, which is a logical combination because NPM1 and FLT3 mutations frequently co-occur. That is a big issue. If you have 2 QTc prolonging drugs, right, you might not be able to use them together. So if you use it with a menin inhibitor that doesn't have QTc prolongation, that might give you a leg up of some sorts. So that I think is a toxicity. The second part is the interaction with CYP3A4. A lot of our drugs have CYP3A4 metabolization. So for example, in AML, the most important ones are probably the antifungal drugs. So voriconazole, posaconazole. They lower, or they inhibit the enzyme and hence increase the level of the drug, so it needs to be adjusted, right? And some of the other menin inhibitors don't have that anymore. So you don't need to remember to readjust your drug if you start an antifungal. So that I think is important, is the second aspect. The third aspect might be the most important one. This has not been clinically shown, but it does. But there's a lot of preclinical data that also has presented at ASH. Is that we know that with revumenib and the other menin inhibitors as well, resistance does develop to those drugs, right? And the resistance mechanisms are multifactorial, but the best or most well-described resistance mechanism is mutations in MEN1, which is a target of the drug. And those resistance mutations are similar to what we see with ABL kinase resistance mutation in CML, for example. Not all the menin inhibitors are resistant against the same mutations. So some menin inhibitors are still retain activity to a mutation that might mediate resistance to another menin inhibitor. And that has to be clinically shown. But this was always the argument to have multiple drugs in CML, right? Why did we not stop with imatinib, right?
Right.
Most patients do just fine on imatinib, but there are some patients who are not doing fine, right? So if we can show clinically, not only preclinically, that menin inhibitors can be sequenced based on the genetic profile of the resistance mutation that develops in a way CML style, for sure not as successful as CML, but at least mimicking that a little bit. I think then there is a use for all the menin inhibitors if they have different spectrum of what mutations they target.
Yeah, no, I think you bring up a fascinating parallel to the TKI story and CML. If it stopped at imatinib, then development would have ceased 20 years ago when it was first approved and brought to market. So great sort of nuanced answer there. Dr. Lynch, curious for your perspective, maybe focusing in CLL specifically. The BTKs kind of have, a fascinating development story in and of itself, kind of all of them jockeying for position. But what's interesting to me now is potential entry of the degraders. And when you look at the data from ASH, it's like, how do we separate Nurix assets, the Nurix asset from the BeiGene asset? It's like the results, granted cross-trial comparison, almost look identical, and the patient population and all these different factors. So curious how you've sort of navigated the BTKs and how you will potentially navigate entrance of the degraders into the paradigm.
Yeah, I mean, I think in all of this, and this is something that Dr. Banerjee knows important to him as well, is their time toxicity and what the impact of the treatments are on the patients as well. And so BTK inhibitors are sort of indefinite therapy as monotherapy. Now, new combinations, of course, doublets, triplets are out there, which allow for fixed duration. But that's sort of the flaw of the limitation of BTK agents is their ability to induce very good partial remissions that can last a while, but require indefinite therapy, indefinite monitoring, so long-term immunosuppression. It's probably early to kind of go beyond what we see here in terms of degraders. It's pretty early to say what their role will be. There was a lot of promise, of course, with non-covalent BTK inhibitors about overcoming resistance. So thinking similar to the CML space, all we have to do is have something that binds somewhere else. I think in reality, we're not seeing pirtobrutinib be durable in that space for people with true BTK resistance mutations. It's a bridge to something else, but it's not the next thing that people can be on for a while. So I'm always going to be a little bit cautious until we have much more robust data to tell us that a BTK degrader can truly eliminate. Who cares about BTK resistance mutations when there's no BTK at all, right? So we'll see. And so I think when it talks, and in terms of toxicity, slight differences between Nurix and the BeiGene product, it's a little too early to make those comments. But I do think patients strongly desire fixed duration therapies. They strongly desire time off therapy. And while BTK inhibitors were practice changing. I mean, if you read the book For Blood and Money, I mean, just people begging to get on these studies, people who were on the verge of death getting on these, and then all of a sudden coming back to life. I don't want to feel like we're not grateful for their impact on the field, but people, now we know we can get fixed duration treatment. So figuring out how to get the good combinations to get the deepest remission possible for as long as possible is what is probably going to win, if that's what you're asking.
Absolutely. Yeah. Thank you for that. Now, kind of rounding us out here, Dr. Banerjee, curious for your thoughts on, multiple CAR T options. I thought Dr. Doris Hanson's presentation at ASH was pretty telling from a real world comparison between ide-cel, cilta-cel. And I think you have to acknowledge, the tech, LRAN, eventual Linvo, ABBV383, which now has Entomig.
You're exactly right. Yep.
Like there's so much, right? And like how do you kind of wrap your head around what's already available, and then just the continued wave of development, and thinking about what is the differentiation? How am I going to justify this to P&T committee if I actually think that this is bringing value to my patients?
Great question. Yeah, there's no good answer, but the only answer I'll say is that we're used to it in the myeloma field of having more than one option that have not been compared randomized. Like we just roll with it and see what happens. I mean, daratumumab versus isatuximab is a great example of that, where they're trying to compete, like the lion and the unicorn competing for the throne. And it's like, you're not really going to win that on efficacy alone. It's going to be on convenience and cost, as you alluded to. I think within the bispecifics, and Dr. Lynch's point about time toxicity is dead on the money, right? So I think that's what's going to win. I think the one that gets people to once a month dosing the easiest and the most practically will be the one that probably gets adopted by most people. And it's hard because a package insert, unfortunately, with this theme that in myeloma, everyone has pushed the MTD, when in real life, the optimal biological dose is always coming in 1 or 2 layers below that. Project Optimus at the FDA is actually, things will get better in time to come, but I think it's hard because, people say like, oh, well, elranatamab will be every 2 weeks and Linvo will be every 4 weeks. And in real life, I use them all the exact same way. I space them out to once a month thereafter. So I don't think you'll see much of a differentiation between the BCMA bispecifics just as monotherapy. I think possibly where you may see one coming out ahead is when you start combining them with novel agents and seeing what happens. I mean, talquetamab is a good example. It's the only GPRC5D right now, but we thought Tal was good, but had some side effects. Like Tal PD works really well, even in patients who are POM refractory, and maybe something about POM something like the immune system, less T cell exhaustion, and I think that will be interesting. Peck and Tal together will be really interesting, and there's a study ongoing of like Elra plus Cevostamab, like combining different targets together. I think will be probably where some of the field is headed. And possibly the golden frontier of bispecific therapy would be if you were able to implement time-limited therapy. So Cevostamab tried that at first, right? Originally 51 weeks of therapy, so 1 year therapy, then stop, kind of like how many of the lymphoma bispecifics are. Now they're not doing that anymore, which is telling. But also, I will say some of my own patients in practice, I've tried to get them off teclistamab, and they say no because they're like, "This drug saved my life. Why don't I just stay on it?" And I'm like, you know what? I don't disagree with you. That's an excellent point. So I think time-limited therapy is not going to necessarily hugely change things in myeloma, but could, because again, as long as CAR T is out there, that'll be it. Within the CAR T space, you alluded to this. Yeah, Dr. Hansen's presentation was great and matched what I see in clinical practice, and obviously, the hope by everyone at Kite is that anito-cel can slip in there, can be the Goldilocks of CAR T that has the efficacy and the safety. It's really not so simple, very hard to compare between trials, and that is comparisons between trials, there's a big deal there, but we'll see. I mean, I think it's interesting because they're even more on the horizon. So GC012F is the one that targets BCMA and CD19 at the same time, which is really interesting. Poseida had an oral at a IMS in Rio de Janeiro with PBCMA Allo1. Dr. Tolaria Bagi presented that. Yeah. And that one is really interesting because this AlloCAR, we haven't really talked that much about it yet, but AlloCAR technically could do a lot. Like, one, obviously no need for bridging. All of our angst and hand retching about bridging would all go away. Two, we're always scared about T cell malignancies after CAR T therapy. Some of that probably from, we've all talked about this pre-existing T cell clones that were abnormal, and you put a CAR into them that cause problems. AlloCARs would fix that, which is nice. 3, AlloCARs would probably be available at smaller centers, I would argue, before autologous CARs are, because it's not about you could take all of us and put us in the middle of a state that doesn't have CAR T, but it's not about us, right? It's about the cell therapy lab, the pheresis nurses, and everything. AlloCAR, you don't need to have a pheresis nurse. You just give the product. And so there's a lot of interesting nuances that could go into it. The big Achilles heel of them is infections and persistence. And so if they fix that, that'll be the other unique hurdle that may come into it. If you'd asked me a year ago, I would have just said, just give up on AlloCARs, but they're out there. They're making a comeback. And so I wouldn't throw the towel on them just yet. And I think that would be the other unique thing that may emerge in the future. So I would say for now, what I said earlier, to answer your question, I would say, how do you choose between BCMA CAR Ts? Yeah, it's a discussion with the patient. Most people will choose cilta-cel. I think most of my patients, practically speaking, for the commercially approved ones. However, I have had patients, especially in earlier lines, who have more to lose. Like, they're feeling okay, a biochemical relapse, but they kind of want to be off treatment, and they're worried about the delayed motor neurotoxicities. And so for them, ide-cel is completely fine. In the future, anito-cel, GC012F, how they pan out, we'll see.
Yeah, I think myeloma is just this sort of breeding ground for options and, figuring out how to plug away and maybe eventually sort of have a patient personalized sort of plan where exactly what option you're going to give them at a certain point in their overall journey.
But it will the one thing we haven't talked about yet, because you've been focusing on active myeloma. The biggest myeloma abstract of ASH was not active myeloma at all. It was the Aquila trial smoldering myeloma, which will destroy. It will literally take all of our algorithms and blow them all up. Then all of a sudden, some of these patients are CD38 exposed going into frontline myeloma, but had a survival benefit. And so, but even for those patients, I'm not going to mandate daratumumab to every single patient with smoldering myeloma. And so we're going to have to do patient-centered decision-making for all of this. And it's going to be hard because people ask that, well, how do you decide between these drugs? And I was like, I don't decide. I talk to the patient and they work with me. We decide together.
Yeah, and I think you provide the perfect segue here, because I was going to ask, in the last, 8 minutes here, kind of a 2-part question. One, what was most exciting to you from ASH as far as presentation wise? And I think you cited Aquila already, so we can kind of talk about a little bit more. And then 2, as we go into 2025, what are you most looking to see most looking forward to seeing, any expectations for additional data sets. What excites you about your respective fields? So maybe if we kind of just go back around again, starting with you, Dr. Banerjee, on Aquila, and then we can go to Dr. Lynch and then round it out with Dr. Stahl.
Yeah, very briefly. So Aquila is fascinating. So it's papers in the New England Journal of Medicine now, which is great. I think basically daratumumab monotherapy versus observation, you saw a PFS benefit, unsurprisingly. You saw a PFS2 benefit, meaning that dara-treated patients, even if they did go on to get it myeloma, still did better than those who didn't, and an OS benefit. And I should add in the slides a very good patient-reported quality of life benefit as well. One could argue that, oh, well, the control arm didn't always get DARA progression, but this is not that kind of a crossover study. You're not comparing CAR T now versus CAR T later. You're comparing DARA once a month now versus DARA VRD induction transplant later. And many patients, when given a scenario, will say, look, I'll take the DARA now, And so it'll be interesting to see basically. And the last thing I'll say is that as much as I was just joking that your DARA will blow up all our algorithms, technically, to be clear, it was only 3 years of DARA. So someone gets 3 years of DARA and bad luck, they have myeloma progression 4 years after that, you can totally re-challenge them with a CD38. Sure. And by 2030, we'll have better treatments available for myeloma anyways. Yeah. I think what I'm most looking forward to, ironically, just to change the topic slightly, IMWG response criteria will be changing. So many of you know, I did this work with 24-hour urine being unnecessary, the abstract about confirmatory PD. That sounds like a who cares, but for example, venetoclax in myeloma, the CANOVA study failed because of this requirement to check the labs twice to confirm PD. The control arm, everyone came off PomDex when they were like, oh, they're clearly, let's move on to something different, but they didn't confirm the PD. Therefore, they were censored. Therefore, there was no PFS benefit. Therefore, venetoclax never made it to the market. So these the bean counting of myeloma, like that stuff matters, and they're simplifying that next year. They're working on it right now, and that I think will be the biggest change to simplify our trials, because it's maddening that our trials say one thing, but we do something else all the time. And I think having at least that fix, that at least we all can agree that this is remission, this is progression, will help a lot.
Yeah, the synergy, it only seems natural that it should be one and the same. Yeah. Dr. Lynch, curious for your thoughts on excitement coming out of ASH, and then what you're most looking forward to next year.
Well, I don't know if I can beat not keeping a jug of urine in my fridge and having that impact, so many patients across the world. So that's probably, if I were a myeloma patient, I'd be very excited about that. I think the next year, I think we're in sort of a holding period right now, because a lot of these really big studies using the agents that we've talked about are ongoing and maturing. And so it's sort of like this calm before the myelomification of large cell lymphomas, for example. And so when some of these read out, it's really going to be practice changing. And I think, the ability to use bispecific antibodies in untreated patients is going to be really exciting in lymphomas. But I know that's not going to be over the next year because those studies are ongoing. But that's kind of what I'm looking for in the future, in the coming years as these mature.
Yeah. Are there a few studies, Dr. Lynch, that maybe stand out? Maybe it's not next year, but there's kind of ones that are garnering more interest?
You're talking about in terms of like ones that are ongoing right now?
Yeah, sort of the up and coming, what's coming next.
Okay, yeah, I'm happy. Yeah, that's why I can just be more specific. I think we're going to have a variety of options in untreated patients. I think based on the initial data, we just know that CD20 bispecifics are very potent. And it would be really great to see if that moves the needle like rituximab did 20 years ago in increasing the cure rate. And so, there's sort of that expression, first cut is the deepest. And maybe in a lot of these, like using some of these really good things up front is better versus, seeing another 3-year whatever, encore abstract of this pivotal data in bispecifics and relapse lymphoma, when that's probably not the right setting. There's CD20 antigen loss. These patients are really beat up. So I think the potential is going to be in untreated patients, but the studies are ongoing. It's just, it takes a while to accrue these. And with these types of endpoints, particularly usually 2-year PFS is usually kind of the closest thing to a surrogate. It's just going to take some time. If you want to ask me about other things that might be interesting for the future, so what do I think about 5+ years from now? I do worry about mechanisms of resistance for bispecific antibodies. So I've heard a lot at ASH about various novel ways, dual targeting bispecifics, non-standard targets. So whether it's 19 or other B-cell markers. So trying to figure out if and enough information about antigen loss as a mechanism of resistance in lymphoma, to be worried that if we're not at least coming up with these next set of tools, we're going to run into problems down the line.
Yeah. Dr. Stahl, over to you. The last few here.
Right. Yeah. In the last 3 minutes, so I think in AML, I think the most exciting part, I think we touched on the menin inhibitors for sure. I think the goal will be to cure more patients with NPM1 mutated leukemia without a transplant. For the older patients who can't get chemotherapy menin combinations, but aza-ven menin combinations, I think one of the most exciting concepts will probably be time-limited therapy. Believe it or not, we AML people are moving towards that as well. We always thought with aza-ven we cannot cure anybody, and this is endless therapy unless they get transplanted. But I think that world is slowly changing. We know based on some of the Australian data, some of the British and the French data, that in some patients, if they have deep remissions, and NPM1 is a perfect candidate for that because you can measure disease with very sensitive techniques like PCR. Even when they get HMA-ven stopped, they can have prolonged treatment-free remission intervals. So the question will be, does menin inhibitor triplet combinations upfront change that and push more people into this attempt for treatment-free remission? I think what I'm most excited about, I have to say, is truly in ALL. In those with CAR T cells and blinatumomab, and the combination of blinatumomab with very potent TKIs such as ponatinib, and there will be newer combinations even tested now. I think in 10 years we will barely ever transplant a Philadelphia positive patient. I think that is very exciting. This is a fundamental change in how we treat Philadelphia positive disease. And even in Philadelphia negative disease, with the administration of blinatumomab, venetoclax, inotuzumab, other agents, maybe consolidative CAR T for MRD, ALL, Philadelphia negative ALL. You will also have more and more patients who will not be transplanted for Philadelphia negative ALL. So I think that ALL will mostly, except of a couple subtypes, become a curable disease without transplant. And I think that's very exciting. For AML, that's the last word. Where we really have not made any progress, and this needs to be said for all honesty, is TP53 mutated disease and disease with MECOM rearrangements. There are no good options for this disease, and there are no really promising new drugs. So I think that is really something that we'll have to work on and focus on over the next couple of years.
Yeah, no, I really appreciate sort of the indication-specific answers from all three of you, and we're right at time here, 6 p.m. I can't thank you all enough for spending the hour here. It was fascinating to hear about your experiences, reactions to ASH, what you're looking forward to. Would love to reconnect with all three of you, moving forward as evolutions continue in their respective paradigms, and as the next wave of innovation comes about in heme malignancies. Pass back to John for any further concluding remarks.
Yes, I mean, it's just an unbelievable discussion across the three of you in the different areas, and greatly appreciated. With that, we'll let everyone go. Have a good afternoon, good evening, or the rest of your day, and take care.
Yep. Happy holidays, everyone.
Happy holidays, everybody.
Yeah, happy holidays. Be well.